Thank you very much. Thank you, Dr. Smith, for consenting to join me when we received this invitation. Thank you to the organizers for the opportunity to talk with you all. It's really neat to see my colleagues in psychiatry and occupational therapy and pharmacy and primary care, an amazing group. So wonderful privilege that we have to speak with both of you. We're going to be talking about trauma-informed pain care, and our goal is to talk about how trauma changes the biology and the psychology of pain. We're going to show you some basic science from biology and from psychology, and then we're going to try to tie that into what do you do as a PCP when you're treating someone with a pain disorder. That's our goal for the next 50 minutes. So pain management has gone through this evolution where, so for a while it was all about, and Dr. Steiner-Hayward alluded to this in that whipsaw that she was talking about, getting dragged between compassion and certainly the pharma marketing that led to pain being the fifth vital sign, to now our opioid epidemic and the APA-AMA dropping pain as a vital sign. So this whipsaw, the pendulum swinging back and forth. Well, trauma, I fear, is going to be like that we have the recognition of PTSD, particularly in a military context, and our own compassion, and a lot of noise being made about trauma-informed care. And I worry that the pendulum is going to swing toward overdiagnosis of PTSD, fatigue in our compassion, and a greater, sort of a growing insistence that, come on, you just got to pull yourself up by your bootstraps. That would be an unfortunate opposite extreme. So I'm hoping, and where we want to be for today, for this next 50 minutes, is to recognize there is a middle ground in all of this between these two, and ultimately I think that's where the pendulum will land. So, Chris, what is trauma?
So this is our first dance, and
can't hear you, Chris.
Microphone up, thank you.
This is our first dance, and I freely admit I'm probably going to nerd out on some aspect of cognitive theory. So in the interest of time, Dr. Phelps has agreed to give me a prod when, exactly. So there's two themes that I'm going to talk about throughout all this, and it's going to be a running concept that I want you to keep in mind, and that is empathy and universal precautions. So the universal precautions is everything that I talk about. Think about it through putting on your trauma-informed gloves. So first thing I have to bring up is trauma and PTSD are not the same things. Trauma is a component of PTSD, but they're very different. All right, so trauma, according to Trauma-Informed Care, Oregon, is a deeply disturbing and distressing experience that's profound and prolonged. And this is actually fear, hopelessness, and horror. That's criteria 1 for PTSD. But let's go into explore trauma a little bit more. So trauma can be interpersonal experiences. That is experiences that reactivate memories of trauma. So say you were in a motor vehicle accident and then you almost got into one on the way here. That could reactivate some of those memories. There's developmental trauma, which is unmet childhood needs. There's historical trauma, which is cumulative emotional wounding. There's also institutional trauma, which is mistreatment due to being part of a societal group. The important thing to realize is that trauma is just not and PTSD just isn't the experience of physical, emotional, or sexual abuse. Trauma is actually underreported and PTSD is underdiagnosed, and that is from Trauma-Informed Oregon, which harks back to the very first thing that Dr. Phelps said. So some people get trauma, some people develop PTSD, and some don't. Do you want to explain the...
So there must be something that's more a vulnerability factor or a resiliency factor that is there before the trauma takes place. And this is where we want to take you into some basic science. I think everyone is familiar with the idea that all these variables in life relate to one another and drive the circle around. Where we want to go, we're going to be talking particularly about trauma today. And the whole point of taking you into the basic science of this loop is to inform your clinical care. So this is not just an exercise in basic science. We hope that this will be in your mind when you see a client with pain. So I'm going to take you through some of the genetic factors here. I think this work is fascinating. I'm going to start with a study that was done in depression, then we'll look at a study that was done in PTSD. Some of you may be familiar with this. This was a study that was done in Australia, a cohort of 1,000 kids. They followed them for 27 years at the time of this publication. It appeared in Science. This is one of the most major demonstrations of this particular genetic phenomenon. So I want you to be familiar with this one. This has been replicated many, many times. What you see here is typical of psychology research. We're going to show you an elaborate slide that demonstrates what everybody already knew, which is that whether you look at it from the point of view of, your up here in the upper left-hand corner, people reporting their own depression, someone else saying they got depressed, getting a diagnosis, or having suicidal ideation or making an attempt. The more stressful life events you have, the more likely you are to become depressed. Right, so everybody knew that, particularly our clinicians. But wait a minute, there's these blue people going like that, and then there's these yellow people going like that. What's the difference between a blue person and a yellow person? And these were really stressful life events: lose a job, lose a spouse, lose a roof over your head. So why is it that these yellow people are just going like this in the face of that, where the blue people are going up and up like that? And the answer is a single gene. It's the gene that codes for the reuptake transporter, the serotonin reuptake transporter, the thing that we block with fluoxetine, Prozac. It turns out that this gene has the gene for that protein has two different lengths. There's the long allele and the short allele. So you remember how this works. You get one copy from dad, one copy from mom. So you can have two of these. You can have two longs, two shorts, or one long and one short. And it turns out that the blue people are the people who got two shorts. The yellow people are the people who got two longs, and the pink people are the heterozygotes in the middle. Does that make sense? So what we see here is a genetic vulnerability that preceded even birth, has just to do with the luck of the dice throw of your parents, that creates a vulnerability factor to your vulnerability to those kinds of social stresses. Lose a job, lose a spouse, lose a roof over your head. All right, so that's lesson one. There is a genetic vulnerability that precedes even birth. Our genetic factor. I'm going to move on now to an environmental factor. Coming out of the same study, they took all of the kids in this large cohort and said, we're going to lump you into one of three groups. You had a really horrible childhood, maltreatment, or we're not so sure, or no, you had, as far as we can tell, no maltreatment during your childhood. They lumped the entire cohort into one of those three groups. And watch what happens to this genetic vulnerability. It disappears. There is no genetic vulnerability in the context of a non-maltreatment childhood. Only it's a two-hit problem. So you have the genetic vulnerability and the context of childhood maltreatment. That's when the gene difference manifests itself. Does that make sense? So to me, this is very profound. It's been shown over and over again since this, but this is one of the most famous demonstrations. So we have genetic factors. Which genes did you get? Environmental factors. Even in just this one study, what was your childhood like? So, and here we're talking about this entire loop. Not just lose a spouse, lose a job, lose a loved one, but there's more to stress than just this, as Dr. Smith will explain.
Thanks. So I think that's everything that Dr. Phelps said, I think is absolutely fascinating. And to help explain this to patients, I use a light switch story. And that is, we have a genetic predisposition for something, so we have a light. But there has to be something that comes along in life that flips that light switch. And one of those things can be, well, a traumatic experience, but also, interestingly enough, chronic stress. So PTSD has stress in the name, so we have to address that. This is a list of mesostressors. So everyone knows that discrimination is a stressful event. But there's also microstressors. So microstressors are also considered daily hassles. And to be able to explain this to patients, I use marbles. So in your mind's eye, picture this big old mason jar. And in this mason jar, picture the prettiest blue marbles that you've ever seen. Then there's all these things that come along in life. Like, I don't know, I got a flat tire in the way here. So the mechanic reaches in and takes out a handful of marbles. Let's see. My wife doesn't think my lame jokes are all that funny. So my wife reaches in and takes out a handful of marbles. And then, I don't know, my kid's sick. So my kid reaches in and takes out a handful of marbles. And before you know it, I've lost all of my marbles. These things build up. But resiliency, that's the anti-trauma. So that's how do we put those marbles back? And we can put those marbles back through cognitive appraisals, so perceived stresses. The key word here is the fact that it's perceived. It's how do you think about your marbles? It's how do you and he's on his next slide we'll talk about some more appraisals. But goldfish. So my goldfish dies. For some people, that's a pretty terrible emotional wounding. Other people, I'm just going to go buy a new goldfish. It's how you think about these things that is the most important. And that was yours.
That was Dr. Smith encapsulating cognitive therapy in one little example between marbles and goldfish.
It's true, actually.
It's painful to think about how much of his work just went into that analogy right there.
Well, you know, I think they said it earlier that it is ridiculously really simple concepts given ridiculously complicated names.
So I showed you the example from depression earlier. This is the example from PTSD itself, where we see that after Hurricane Katrina, who gets PTSD, meaning DSM diagnosable PTSD after Katrina? It's not everybody. It's much more the blue people. Remember, those are the two people with two shorts, more over the people with at least one long, if not two longs. So this is the genetic vulnerability. But interestingly, it only showed up in the context of low social support. So this gene difference was gone for people who didn't go it alone after Katrina, who had people around them to help them. And what's the explanation for that?
Well, glad you asked. So perceived support. This goes back to cognitive appraisals. Social support is a resilience factor. So this is how you put more marbles back. Social support will fill up that jar. So there's lots and lots and lots of different types of support. So there's tangible support, emotional support, financial support. The one that really matters is perceived support. It doesn't actually matter if you have support. Only thing that really matters is if you think you have support. So it's actually a really interesting study that came out of that. And, well, I guess I should hit that.
All right, so again, we want you to understand that this loop is pernicious, it's prevalent, and that there's much more to it than what we would, if you look at someone else's life, you may not be able to perceive their own experience of that life, so that someone could have quite a few people around them and yet perceive themselves as lacking social support. And finally, in that basic biology of understanding this loop are the epigenetic changes that accompany this. And in part, this is mental health showing off here to show you that, you know, back in medical school, the psychiatry stuff would come up and people would sort of roll their eyes. We want to show you that there's a basic science behind this that is very sophisticated now. And in fact, medical students from that institution right across the road are no longer getting the eye roll when they talk about going into psychiatry. It's really exciting. And it's because of work like this. So look at the title of this study. DNA demethylation mediates gene-childhood trauma interactions. This from Nature Neuroscience fairly recently. So I want to show you just a little bit of what this work looks like so that you appreciate how sophisticated our understanding of these kinds of things now is. So I won't take you through all the details, and you may not be able to follow much of it. Some of this will be gobbledygook to some of you. But if you remember some of your basic biochemistry, we have cortisol, which in humans is the mediator of the stress response in part, goes through this elaborate complex of a glucocorticoid receptor and makes its way into the nucleus of the cell. A whole series of events then follows, and we're looking, in this case, at a hippocampal neuron. One of the things that then follows is a change in the DNA that codes for the very molecule that is the chaperone for cortisol into the nucleus. That molecule right there, that's the DNA for this FKBP5. That is if we take this and blow it up, we're looking at these blue guys, which are methyl groups, and trauma is the removal of methyl groups. It's a demethylization such that people with a trauma history have 50% less methylation at that portion of their DNA, the very mediator of the stress response. So people who have a history of trauma are walking around with a biochemistry that is different than people who do not have a trauma history. It gets into their DNA. Moreover, that DNA gets handed to their children, who then start out from a very different starting point in life. So all three of these things, and this is my ending slide for this segment, this is the one that I want to stick in your head. All three of these things tell us that it's not a level playing field. And I use this, as you will see when we get to our clinical work, I use this to recover my empathy, to find my compassion again when I'm faced with someone who is berating me, treating me in a demeaning fashion, or so bereft in my office that it feels as though I'm being dragged down with them, and I don't like the feeling, and I can feel them kind of doing it on purpose. How am I going to find my compassion for that person? This is one of the ways that I remember that. They didn't wish for any of this.
So let's do some case examples. I should just leave it up for a little bit longer. So this is an actual patient of mine and Dr. Godek's. So 50-ish year old woman with fibromyalgia. So she was presented to me for pain management. And for some of this. She was a mess. She was a very difficult patient. So during the biopsychosocial intake, I asked one question which I think changed her entire course of treatment. So she revealed to me that she had a history of childhood sexual abuse. I was the first person in her life that she had ever said that to. She didn't tell her husband. She didn't tell her children. She didn't tell a priest. She didn't tell Dr. Godek. I was the first person she ever told. Let that just sink in for a second. She also had no interest in specialty mental health at the time. And let's talk about trust. So she trusted me enough to tell me that, and she trusted me because of that guy, because of their relationship. I freely admit that I came in on the coattails of that relationship, of that patient's relationship with their physician. So what did we do? Well, I immediately went and informed the PCP about the results of the intake. And I remember one of the very first things that we said was like, now all of these behaviors make sense. Like the fibromyalgia, the pain, the noncompliance, the maladaptive behaviors. But I'm going to tell you right now, we just did a disservice to that patient because that's not really trauma-informed care, is it? What we just did, we were looking for a collection of symptoms rather than looking at that patient through like a Gestalt lens, which we don't need to understand where these behaviors come from. You know, it's great. But what we really need to do is to figure out what we're going to do with them. So what did we do with her? So we worked on distress tolerance. We also worked on motivational interviewing for building up trust to get her into specialty mental health. And I have to stress this again. Trust is the key to an empathetic relationship. So, all right, next one. When patients are having maladaptive behaviors in your office or with you, you have to remember there's a reason for those behaviors. Often behaviors serve as a survival function. So a good example of this would be layering. We've had patients before who go to bed and they wear 3 or 4 different layers of pajamas, or they come to our office and they're wearing multiple layers of clothes. While that behavior was adaptive at one point in their life, it's maladaptive in our office, it's maladaptive in their lives. But we have to remember, secondary gain, people just don't engage in behaviors on a whim. They engage behaviors because they serve some function somewhere in their life.
So this behavior, for example, you see in the slide, that was adaptive in one setting, and yet when you see this in your office, it doesn't feel very adaptive to you at the time. It doesn't seem adaptive for the patient.
All right, so we started discussing behavior. Let's start moving to the body. So trauma and pain is a biopsychosocial experience. We feel emotions. It's in the name. It's feelings. So this slide is taken from the PainWise group that Dr. Godek brought up. And I think it's absolutely fantastic. It's from the Proceedings of the National Academy of Sciences, and it shows where we feel emotions. Look at where we feel fear. Look at where we feel disgust or anxiety. Now, or actually in depression. Now think about this in the context of pain. So that patient is more likely to engage in scanning behaviors there, more likely to be hyper-aware of sensations. And for depression, if someone has an injured foot or extremity, that makes a lot of sense with psychomotor retardation. Like, it's really hard to even move that limb. It's actually really interesting.
So what does this have to do with pain control? I hope that that's getting fairly obvious. But we'd like to borrow a couple of slides from Dr. Kevin Cuccaro. Kevin, could you stand up for a moment? Kevin is also a pain specialist who's pioneered this work. When I saw this presentation of his, I thought this is where I want to take off from for this talk. So now as we're coming into the clinical phase, thank you, Dr. Cuccaro. Chris, could you explain? We're going to do our version of Dr. Cuccaro for you.
I freely admit I'm not going to do it justice, but so pain is like fire. To have fire, you need three things. You need fuel, oxygen, and heat. Now let's talk about pain. To have chronic pain, you need the sensation, but there's also the emotional and the cognitive components of that. And as a psychologist, well, I really like emotions and cognitions. All right, so when you think about this, think about it with your patients, and I think this is absolutely fantastic. I give them this handout all the time, Kevin, so just so you know, that pain is real, and it can be exacerbated, and that's the key word here, exacerbated by both the meaning of the pain and the cognitive appraisals of whatever that pain is. All right, this is my favorite part, so I'm totally going to nerd out now. So this is the Yerkes-Dodson's law. This is, can I borrow that? So this is the concept of eustress. This is the concept of eustress and de-stress. So we need a little bit of stress to get anything accomplished. Like there's no reason why I would have written a paper on the American Revolution in college if I didn't have to. The problem is once we start having too much stress, our performance actually starts to decline. And that's the fight or flight response. So if you just think about it simply, the amygdala and the limbic system take over, and your frontal lobe pretty much, we'll say, shuts down. I like to describe it as patients as rational thought takes a holiday. And so what that leads to is once we start to experience distress is more irrational beliefs, more irrational cognitions, poor decision making, acting up in your PCP's office. And Yerkes-Dodson's law directly relates to catastrophizing. So first thing I have to do is give a shout out to a few of the researchers here at Samaritan, because they actually wrote a paper on catastrophizing and pain. But what is catastrophizing? So catastrophizing is hopelessness, magnification, and rumination of an event. So a great way to describe it is making a mountain out of a molehill. So what does this mean? So let's use broken foots. So I broke my foot. It's never going to heal. This is the worst break in the history of mankind. I mean, have you guys seen the x-ray? And I can't stop thinking about how bad this break is, and it's never going to get better. So that's, you can think of that as catastrophizing. Catastrophizing is a core component of anxiety. So what is anxiety? Anxiety is I overestimate, I've had a negative event, I overestimate the probability of a negative event occurring, and then I underestimate my ability to deal with it. Hopefully that sounds a whole lot like marbles. So,
meaning marble removal?
Marble removal. So, thanks. All right. So since anxiety leads directly into kinesiophobia, kinesiophobia is the fear of movement. So I can't walk on this foot. Have you guys seen it? Like, you know, I'm just going to have to sit. So as we all know from chronic pain, that movement is one of the best things for that because of increased muscle tension, you know, whatnot. But also kinesiophobia leads to a lot of guarding behavior. I'm much less likely to use it. So as providers, what do we do? Actually, I think this might be my favorite metaphor. So we understand thoughts, how thoughts affect behaviors, but let's talk about us as clinicians. So do you guys ever have those patients when you're scrubbing your chart in the mornings and you see a name on there and you're like, Jesus, I hope this person doesn't show up. I really, really hope they don't show up. And then you go to lunch. And by go to lunch, I mean you sit at your desk and do charting. And then your 1:30 appointment, that's your first one in the afternoon, you see that black dot. You see that black dot appear in Epic, and you know that patient's here. And you're like, I got to go in there. So guess what you're doing? That's countertransference. You're creating a self-fulfilling prophecy, and you're taking that into the room. So I wonder how much of that patient's behavior is from us, and how much of that patient's behavior is technically from them too. Because we have to approach patients with empathy and positive regard. We're not looking at patients through a gestalt lens of their experiences. Remember I said about universal precautions, we have to wear our trauma gloves. We don't know if this patient is just stressed out, overwhelmed, had a traumatic experience, has PTSD. But what we do have to do is don't be another source of their trauma. And this is one of the best quotes that I've heard about this, is that it's not what's wrong with you, but it's what's happened to you.
Just a reminder, this is where I turn to these kind of data to recover that empathy and positive regard so that I can walk in and avoid re-traumatizing the patient by exhibiting my frustration, my anger, and my disinclination to do whatever it is that it is clear that they want from me.
Universal percussion is going to hit that one. But you're not alone. As providers, you're not alone, and your patients aren't alone either. So there's always referral to the behaviorists and the community providers.
And Chris, do you think we could just, I know we have some of them here, Dr. Sissing, could all of our behaviorists in the room, could you all just stand up? We have a whole bunch of them. So Dr. Johnson, yeah. That's who we're talking about. Thank you.
But in the interest of time, I won't nerd out on all the different types of treatment. I will just say there's a lot of empirical-based treatments. In fact, just take some letters together, put them together, you'll probably find an empirical-based treatment someplace. But this is what I really want to get to, is movement-based classes in pain education. All right, so this is what Dr. Godek presented about 30 minutes ago. And this doesn't make a lot of sense. This is a lot of words on a PowerPoint page. I know it kind of freaks you out. So,
well, we're doing pretty well on time. So could you actually pull your handout up now? This was at your place when you sat down. It's one in the pile. And there is a page that looks like this, because Dr. Smith is going to walk you through what are these classes, what are the core contents in each of them. And then I'll take over and show you a second handout that was right behind that one that shows you more details. So, Chris?
Sure. So if you think about it as a reverse linear model, so PainWise first steps, that is the combination of physical therapy and psychologists. And I think that's absolutely fantastic because it addresses two things that I just brought up. It addresses the kinesiophobia and it addresses the catastrophizing. So this is the classes that were developed by Dr. Lewis and Dr. Ellis. And I think it's a great first step. It's like Pain 101. So if you have patients that are just need a little bit more psychoeducation or to be introduced into the concept. And actually, going back to social support, I left this out and I was supposed to do this on the previous slide. Because social support is a resiliency factor and such a big deal, I have to bring up some of these groups, and specifically the fact that PainWise has, they now have a coffee group. So a few of the members graduated from the PainWise 101, and now they actually go out and have coffee with each other. So they have similar experiences, share their stories, go walking together, and I have to say that's wonderful. That's what we're trying to do. So Beyond Pain, that's available here in Benton and Lynn counties, and that is for your patients who need a little bit more support. I think that we have our group leaders. Is that Leanne back? Hey, could you stand up? So she's the one who developed this, and it is fantastic. So it's for patients who might be in pre-contemplation to contemplation stages of change and just need a little bit more support to engage in health behaviors. And our very last one's living well with chronic pain. A lot of peer support. You can think of that as your patients who are good to go. They're already in contemplation or action and just need some place to help facilitate this.
And then one more set of groups that we've added on top of this. There are going to be some of your folks who are not going to go any of those groups because for them the trauma history kind of outweighs. They're too phobic of engagement where, between Dr. Godek and Dr. Smith, they were able to bring that woman in the case that they described. Some of your clients are just not going to be able to get to one of these classes. And for many of them, that disinclination may be more than what you can overcome with motivational interviewing, and it lies in the trauma. So we need now a class that is really, in some ways, more about the trauma than it is about the pain. And so we've kind of shaded over from the primary care, we're addressing pain, to no, we're more in the mental health realm when we're addressing the trauma. And yet we need to do this in an efficient fashion because we know that there are many, many, many of your patients out there who fall into this bucket. So Dr. Godek and Chris and I would talk about the 3 buckets, the buckets that we can relatively easily address in primary care. And the third bucket, which is this is going to have to go to specialty mental health care. You need to get this patient to come see us at Samaritan Mental Health in Corvallis. And then there's this second bucket, and it's got a huge number of people in it. And trauma is so often the common ingredient for people who fall into this middle bucket. So we've asked our colleagues in mental health to develop groups that are similar in terms of their ability to address pain, but focus on the trauma just as much. And we have, fortunately, 2 colleagues now working with Samaritan Mental Health who are preparing these groups. And the last handout in your collection, it should have been right next to the one that we've had up here. It has a blue flag banner in the upper left-hand corner. Bill, can you just remind me what this thing say up there? Thank you. Mental health groups in primary care. Could you pull that one up? This is a description of some of the components, thank you, Bill, that go into these classes. And I'd like to introduce you to one of our 2 group leaders, Jana Svoboda. Jana, could you stand up? Jana, my colleague from Samaritan Mental Health. So I hope what you're seeing here is that, oh my gosh, look at the wealth of riches that we have developed through the pain and the coordination of the PainWise group, so that here's where we're going to go with all these resources. Remember that, one last ditzel here, and I really do regard it as a minor thing relative. We do have consulting psychiatrists who are available to primary care in adult work. That's me right now. Through our mental health specialists, many of your clinics have mental health specialists embedded in your clinic. So if there are other targets that we ought to think about in terms of particularly medication swaps or simplifications or taper recommendations, you do have a psychiatrist available to you as part of this package. So this is the package that's available in terms of adding treatments. And again, as Dr. Godek had mentioned earlier, we're talking about adding treatments before we start removing things. In other words, it's not about taking away, which our patients are so afraid that we're going to do. And we have the legislation now coming that's going to force you in some respects to do some of that taking away. But we have these many things that you can be adding to their care before we get around to this removing step. Does that make sense? So our summary slide, and we've deliberately left a good deal of time for questions because we could talk for a long time. But we're talking about a kind of a sea change in the way we handle pain by bringing in large teams to be available in primary care. So to summarize, and the thing that we want you to walk out of here with in your head is this is the series of steps. What does a PCP do in the context of what we now call trauma-informed care?